Yeah, now we are able to hear you.
Sorry about that, Naresh. So as I was saying, John McCulloch, who is widely regarded as the pioneer of microsurgery within the spine, described three cardinal sins in spine surgery. The first is operating on the wrong patient, where he emphasized the importance of patient selection. The second cardinal sin is that performing the wrong operation on the right patient. Now you have chosen the appropriate patient, but you need to select the correct operation. There is a lot of fancy operations which are coming in, and sometimes these may not be most appropriate for your patients. And the third one is performing the right operation, but at the wrong level. And this is what we are going to talk about today, wrong level spine surgery. The US Joint Task Force for Prevention of Complications during surgery has labeled wrong level spine surgery as a never event. A never event is an event which is completely preventable and occurs because of some overlooking or some mishap on the part of the doctor. The incidence of wrong level surgery varies between 0.15 to 2%, but this is supposed to be widely underreported. In a survey of 415 neurosurgeons belonging to the American Academy of Neurospine Surgeons, they reported that 50% of them had performed one or more wrong level spine surgery. In fact, it is thought that 35% of orthopedic surgeons will perform a wrong site, wrong level surgery sometime during their 25-year orthopedic career. Wrong level spine surgeries are very common within the lumbar spine, but that probably reflects the fact that most common surgeries are within the lumbar spine. Thoracic spine surgeries probably are the most difficult in terms of level isolation or identification. The most common wrong level is usually the immediately cephaloid one. 68% of wrong level surgeries are noticed intraoperatively and remedial action can be taken then and there. But 27% of patients in error is realized more than 24 hours of the surgery, and this results in a lot of embarrassment for the doctor and often malpractice suits. Wrong level spine surgery, if you have done, malpractice suits are unforgiving, and 84% of the time the suit is settled in favor of the patient. So what are the causes commonly of wrong level spine surgery? The first and foremost, which is what Ram emphasized in his lecture, is the failure to obtain preoperative X-rays. Today, patients walk into your clinic with an MRI scan, and we identify the pathology and go ahead with surgery immediately without getting a preoperative X-ray on occasion. What happens here is there are often transitional segments, sacralization of the lumbar vertebra, lumbarization of the sacral vertebra, or fused segments, which lead to wrong level identification intraoperatively. The third problem is failure to confirm the side on which you want to operate. There have been times I have also been guilty where in my hurry to start the surgery and patient has a right-sided lumbar disc prolapse and I've just gone in and stood and started left-sided exposure only to realize later, oh, I've exposed the wrong side. So it is vital that the side and level should be confirmed preoperatively. The most common wrong levels, I feel, are within the lower cervical spine, where visualization is difficult even with proper imaging, and within the upper thoracic spine. The rest of the thoracic spine is vulnerable to wrong level surgery when the pathology is like a disc prolapse or an intravertebral tumor. The vertebral body contour is normal. Another big problem is inadequate intraoperative X-rays. This could be because of you don't have a good machine, you do not have an appropriately well-trained technician, if the patient is not properly positioned. And of course, there are certain anatomical hurdles like obesity, scoliosis, osteoporosis where the bones are not clearly visible, or few segments in the spine. And finally, of course, are wrong surgical techniques. Let me elaborate a little bit on this. The first of which is inadequate patient positioning. If you have a horseshoe headrest when you are positioning in this for the cervical spine, often you will not be able to take a good AP view because the metal will come in between and block your AP view. So when you operate at C7T1 in these patients, you may not be able to adequately identify the level. Inadequate surgical exposure. If you're not adequately exposed the spine, there is a lot of muscle left there, there is a lot of bleeding going on, you may land up operating on the wrong level. A lot of people rely on the skin marking. They mark the skin before starting the surgery, and they rely on that to identify the surgical level. You must remember that the skin is mobile, and therefore once you expose, you may still end up at the wrong level if you rely on that marking. Some people rely on the counting of ribs to identify levels within the thoracic spine. It is difficult to count ribs, and there may sometimes be anomalies where one or more ribs are absent, and you may ultimately end up going to the wrong level. Again, some people after exposure rely on checking the mobility of the L5S1 segment. What they do is they use a nibbler, hold the L5 spinous process and move it. And if this is the first mobile level, they can think this is L5S1. They may land up in problems if there are transitional segments. McCulloch described what he called as the laminar trap. Let me elucidate it a little further. And the final problem with improper technique is lack of suspicion when you operate and you land up not finding the things which you had seen on your preoperative X-ray and MRI. In this case, you should be suspicious and get further X-rays intraoperatively. The laminar trap, as described by McCulloch, is a situation that when one ascends up in the lumbar spine, the cephalad lamina overhangs the disc space more and more. This occurs even more when the disc space is collapsed. So if you put a needle looking at the disc space straight down, what happens is you actually may land up on the cephalad lamina. And after exposure, you may follow that lamina upwards and be directed into the disc space above. And therefore, in the lumbar spine, the kyphalad level, the level above the pathology, is the most common wrong level surgery. So how does one prevent wrong level surgery? I think the key is just meticulousness and obsession. As Dr. Shankar mentioned, you are the one responsible for the patient's well-being, and at every step of the surgery, you must make sure that you are in the right place, doing the right thing for the patient to prevent problems. So what we do here in our hospital is that we mark the level and the side of the surgery before the operation. When the patient is in the holding area, when he's not yet sedated, you ask him which leg is painful, confirm it with MRI, and draw an arrow on that leg so that you know that this is the painful leg. Intraoperatively, before the patient actually you start the surgery, the nursing team does a timeout where one again confirms the level. Always obtain preoperative X-rays. Match your preoperative X-ray with your preoperative MRI. Remember that intraoperatively you are going to see you are counting levels from below upwards under Siam control, which is an X-ray. So you must identify last mobile segment on your preoperative X-ray, and based on that, you look at the pathological level. Typically, most radiologists count the vertebrae from above downwards on their MRI, and accordingly, they write L4-5 stenosis, whereas on your counting from below upwards may actually be L3-4 or L5-S1. So therefore, always match the level and say that when you are operating, you're operating on the second last mobile segment rather than saying that I'm operating at L4-5. Preoperative level marking is something which is very useful. Some people to use an immovable marker for thoracic pathology or even in the lumbar spine. They put a needle into the cephalad spinous process, and once the level is confirmed, they cut off the needle at that point and remove the needle intraoperatively. When I was in England, what we used to do is send the patient preoperatively to the radiological suite, and the radiologist would inject methylene blue into the ligamentum flavum and the interspinous ligament, so that when you expose, you could see the dye and know that you are at the right level. This is especially important and useful in thoracic pathology, or when you are suspecting that patient we may not be able to get good quality intraoperative x-rays. Proper positioning and adequate exposure has been amply dealt with. Good quality intraoperative imaging is vital. I will not do a vertebroplasty on the day that my radiology technician is not there. These are procedures which are completely technician dependent, CM dependent, and you must have good quality imaging in order to be able to proceed safely with surgery. Routinely, you must confirm levels not only at the level of skin, but after exposure, you put in a Penfield 4 below the lamina and check the level. And again, at the end of the surgery, put in a probe into the disc space and check the level. If there is any mismatch between what you are expecting looking at the preoperative MRI and what you are finding intraoperatively, do a recheck imaging. So finally, to end with, how do I do and how do I prevent wrong level surgery in my patients? I always get preoperative x-rays, both AP and lateral view. I spend some time comparing these AP and lateral views and finding the pathology on the MRI so that I know precisely which level I am operating on intraoperatively. Always talk to the patient before induction, find out the pathological side, the pathological level, you confirm it in the holding area and check his chart so that you know you are not missing anything. When you are inserting a needle, don't try to insert the needle opposite the disc space. Instead, try to insert the needle between the two spinous processes. When you do that, you are exactly at the level so that in this way, you will avoid the McCulloch laminar trap. You then follow the lamina upwards into the disc space. Once you have exposed adequately, put in a Penfield 4 below the lamina or use an Ellis if you have exposed bilaterally and confirm the level. If there is any mismatch between intraoperative findings and preoperative imaging, check again, put in a probe into the disc space or into the laminotomy defect and make sure you are at the right level. To conclude, I would like to end by saying that wrong level spine surgery is almost unforgivable. And it is usually a surgeon error, either it is surgeon fatigue or the surgeon has not been careful, he's in a hurry, and this usually results in the problem. There is very little excuse, and the courts certainly do not forgive surgeons who do wrong level surgery. So beware of that. Thank you very much.